that the mortality will increase associated with HCC. Therefore, it's very important to decrease both the incidence and also the associated mortality. We published our data on long-term comparative local tumor control in the liver, treating primary and secondary liver malignancies, and could demonstrate excellent local tumor control and survival for HCC using the whole armamentarium what we have for treating HCCs, electrochemotherapy, radiofrequency, microwave, cryo, and also high-dose brachytherapy. Well, therefore, our goal is to share our good results with regions all over the world where the incidence of HCC is much higher than in Germany, for example, and to collaborate to achieve better therapeutic results and decrease the mortality associated with HCC. Well, ablation itself is already an integral part of the guidelines and guideline recommendations for stage-adapted treatment of HCC. In very early stage and early stage, ablation is one of the main therapeutic options for the treatment of HCC. For sure, we are talking about radiofrequency ablation, microwave ablation, but not about ECT because it's very modern ablative therapy. Well, if we take into account what kind of the ablation armamentarium to date consists, is we have a lot of non-thermal and thermal ablations, hyperthermic and hypothermic, but we have also non-thermal ablations like chemo ablation, like the ECT. It's a little bit similar to the IOE, to the irreversible electroporation, but it's not the same because ECT, it's a reversible electroporation. I'm going to explain it later, a little bit more precisely later on. Well, with so much choice, there's a risk for losing the focus. Therefore, we have to look to the evidence. If we look to the evidence on therapy options in HCC, the majority of the evidence we have on the use of sorafenib, on chemoembolization, but also on radiofrequency ablation and PEI. And as we just heard, also on Y90 radioembolization in the liver. For sure, we have very little evidence for the efficacy of ECT in HCC. Well, on the one hand, it's well known that the rationale for the chemoembolization is the dominant arterial vascular supply of the HCC nodules, and the prerequisite for the embolization is the neovascularization. It is a physiological prerequisite for tumor growth, triggered by VEGF, and it's a protection mechanism to avoid tumor ischemia, and for sure it's a roadway for TACE. But on the other hand, we realized in our own scientific work that hypervascularization is also beneficial for ablative tumor therapies. We achieve a better local tumor control using ablation in hypervascular tumors that in comparison to intermediate and hypovascular tumors. Well, where is the combination or where's the technology transfer for ECT? What is ECT exactly? ECT, it's a chemo ablation that enhances the local efficacy of a chemotherapeutic drug using electroporation. The most commonly used cytostatic drug is bleomycin. This is a slow to non-permeant cytostatic drug with a excellent efficacy against a majority of the tumor cells like adenocarcinoma, ovarian carcinoma, sarcoma, breast cancer, BC, and so on and so on. The electroporation is used to push the bleomycin, which is slow permeant or not permeant, into the intracellular compartment to be effective in terms of a chemoablation. The three antitumoral effects of ECT are, first, the death of mitotic tumor cells due to the chemo effect of bleomycin. Further, we have a tumor cell ischemia. It's a kind of vascular lock caused by the electroporation. That means that ECT is also a kind of electric case, maybe, can be called. And last but not least, we have a stimulation of the immune response far higher than in available with hyperthermic ablation techniques. ECT has a lot of advantages compared to thermal ablation. On the one hand, we can use it in large and non-spheric and deep-seated tumors in the immediate proximity of risk structures. And bleomycin, as chemoablation, is not sensitive for heat sink effect. The drawback is, because it's quite new therapy or technology, there's not so much experience and evidence as for older ablation techniques like radiofrequency ablation or microwave ablation. In our study, we could demonstrate an excellent local tumor control for HCC. We could also demonstrate that the lesions treated with ECT were far bigger than the lesions we treated with radiofrequency, microwave, cryo, or even brachytherapy. And as already mentioned, we have a better local tumor control in hypervascular tumor. 95% of the lesions had a big volume, were treated with ECT, and 91% of the lesions were in challenging locations. That's very important because they were in the immediate vicinity or proximity of critical structures like portal veins, hepatic veins, central bile ducts, diaphragm, etc., etc. Therefore, the chemoablation as technique should be considered as a very effective alternative to thermal ablations, hyperthermic or hypothermic also, and it can be used also for non-ocular permeant chemotherapeutic drugs, and it's also effective in tumor entities with a very low radiation sensitivity. What are the indications for ECT and HCC? In principle, for sure, always when the local tumor control makes sense in the context of multimodal interdisciplinarity, in large volume and non-spheric lesions, because it's a multi-probe technique, you can use multiple electrodes to achieve a perfect coverage of the tumor, as you can see also here. In challenging locations, where it's important to preserve risk structures and collagenous structures, and for sure where thermal ablations are restricted in locations where pain after thermal ablation is inevitable due to heat sink effect. What are the best lesions to start with? You should treat at the beginning of your ECT career, maybe. It should be hypervascular lesions, maybe medium size at the beginning, easily accessible. No ribs in the way to be able to maintain parallelity, because the parallelity and the distance between the probes, the electrode tips, it's very important. It's mandatory, and the patient should be capable for general anesthesia. In long term, you can proceed with targets that are otherwise challenging to treat, in the liver dome, liver hilum. In entities that are chemo and radio resistant, and for sure, last but not least, to improve immunotherapy. Here are some examples of HCCs I treated with ECT. In the first case, it was a lesion without proper coverage. Therefore, I wanted to avoid any kind of bleeding. And for sure, if you are using ECT, due to the vascular lock, you are going to realize that you will never, nearly never, will have any kind of bleeding because of the vascular lock. And 2 days after, and in long term, we see a complete ablation of the target tumor. In this case, it was a challenging location in the liver hilum. We were able to access it, and in long term, we had a complete necrosis and death of the targeted tumor. This was also a case of HCC after hemihepatectomy on the right side. We targeted from the front, and we were able to cover the entire volume. And in long term, we see again a very well sharply demarcated necrosis of the tumor. And last but not least, also a small HCC nodule, also in a central location, not as challenging as this one, but we achieved excellent local tumor control. As we have a look to these images, I'm very impressed by the precise delineation of the killing zone after ECT in HCC. And for me, these images are very promising that ECT offers a very effective, precisely contoured, and well tolerable and ablation, especially for HCC because it's hypervascular. Summing up, ECT expands the interventional armamentarium also for HCC in a special way. We achieve excellent local tumor control, and it might be used also for supporting the immunotherapy. And as the primary investigator of the RESPECT registry is the registry on percutaneous electrochemotherapy in the liver on primary and secondary liver malignancies. We are accumulating data now at the moment, and in 2027, I'm happy to present you the more data on the efficacy of ECT in the treatment of HCC, because then the complete registry is closed and we are assessing the data. Thank you very much for your attention, and thank you very much for the invitation. And I wish you and us, all of us, a peaceful New Year.
Thank you very much for this nice talk about a very hot topic. Now our next speaker will be Dr. Mohammed Shakir from Ain Shams University. He will talk about genicular artery embolization. Dr. Mohammed is a professor of interventional radiology at Ain Shams University, and now he's the head of the interventional radiology unit at our university.
Thank you, Professor Dr. Mohammed Gharib.